Hello everyone, how are you guys doing? And please do like or do comment so that I would come to know that these videos are helpful for you. Otherwise, now I can see that there are much views, but I cannot see any response. So I'm not sure like if these videos are really helpful for you or what I am doing. Do I stop making these videos or like I have no clue what is like what you guys are getting. So please let me know. Even if you do not want to comment, you can message me separately on my Instagram or on Facebook, or but please let me know, because that's the way I would know that and this also would give me some more strength or maybe more excitement to make more videos. Otherwise, now it's like only one way process. I'm the one who's talking, and there is no response from you guys. So, yeah. So that's all. Okay, so we will start with today's video, which is the salivary gland infections. This topic is not very important according to your exam, but you should know everything, right? Then diagnosing salivary gland infections. Swelling of parotid, submandibular or sublingual salivary gland may indicate salivary gland infection. However, a non-infective cause of swelling, which is the salivary gland obstruction, is more likely. Outline potential causes of salivary gland swelling. Benign mesenteric hypertrophy, lymphadenopathy, or acute spreading odontogenic infections may be mistaken for salivary gland swelling. So we will read in this box what could be the reason when your patient would complain about that he is having swelling of salivary gland. So the most likely cause could be the inflammatory, which could start either from the bacterial infection or through the viral infection, or any chronic infection such as tuberculosis or actinomycosis, or any autoimmune diseases such as the Sjogren disease, Sjogren syndrome. And the other common cause is the obstruction. If there is any obstruction in the duct and the saliva is getting pooled there and there is swelling, so there might be any stones, or there might be any trauma to that duct, or there is a retention cyst which is called mucous retention cyst or ranula. Then the other causes could be metabolic, like if the patient is obese, if he has hypothyroidism, you know that those patient has oval and round face, and even if the alcoholic liver disease or the malnutrition. Then there are some type of tumors that can also lead to swelling of salivary glands. More common are the benign, which is the pleomorphic adenoma or the monomorphic adenoma. Then there are certain malignant tumors such as mucoepidermoid carcinoma, adenoid cystic carcinoma, adenocarcinoma, or lymphoma. And there are certain type of drug or food hypersensitivity which can also lead to salivary gland swelling. Then what test would you do for the diagnosing? Is the ultrasound or the computer tomography may be necessary to determine the diagnosis. Then acute suppurative silidinitis, it would include parotitis. Acute suppurative silidinitis is usually caused by, so these salivary gland infections are more commonly caused by Staphylococcus aureus bacteria, though occasionally it is polymicrobial in adults. The glands are enlarged and often, so if there is any infection, so there would be the signs of infection, which would be swelling, hot, tense, and there would maybe pus coming out from the duct. The patient is usually systematically unwell. It means that he would have fever, he would be dehydrated, and has difficulty swallowing. So what would be the management for these patients is the urgent referral. So what you need to do is urgently refer them to the hospital, because their treatment would be completed in the hospital by giving them rehydration, culture and susceptibility testing of their blood samples. If the swelling is fluctuant, intraductal or surgical drainage, send pus for culture and susceptibility testing. Antibiotic therapy given intravenously initially and then orally once the patient can swallow, because there is a swelling on his with respect to the salivary gland, so there would be the there would be difficulty in mouth opening. Okay, so first we need to give those patient IV antibiotic, and then we can start with the oral antibiotic. If S. aureus is identified in a blood culture, treat as S. aureus bacteremia. If the results of blood culture indicate a polymicrobial bacteremia, then seek expert advice. Then what intravenous antibiotic you need to give? This is mainly done in the hospital, but you just for your knowledge, initiate empirical antibiotic therapy with flucloxacillin 2 gram IV 6 hourly and switch to oral therapy once the patient can swallow. If there is a risk of MRSA, then you can prescribe vancomycin IV. And in some regions, based on local community acquired MRSA susceptibility, clindamycin or lincomycin is also a suitable alternative to vancomycin. So you can give clindamycin 600 milligram IV dose, or either lincomycin 600 milligram IV dose. But if the patient is immediate non-severe, or patient has immediate non-severe or delayed non-severe, then you can give the cephalosporin. So which cephalosporin you will give is the cefazolin 2 gram IV 8 hourly and switch to oral therapy once the patient can swallow. But if in case the patient has severe or delayed severe hypersensitivity, then you can prescribe the clindamycin and the lincomycin dose. Then what would be the oral continuation therapy? So once the patient can swallow, which oral therapy you can prescribe to the patient is if the results of culture and susceptibility testings are available, then modify the therapy accordingly. But if the results are not available, then you can start with dicloxacillin 500 milligram orally 6 hourly for a total of 10 days, and the flucloxacillin 500 milligram orally 6 hourly for a total of 10 days, which would include IV plus oral, altogether 10 days. For patients with risk factors for methicillin, which is the MRSA, if you need to give them the oral dose, then you can give them trimethoprim plus sulfamethoxazole, and or you can prescribe them clindamycin 450 milligram orally. So here the oral dose is different from the odontogenic infection dose, which is the 300 milligram. Okay, and if the patient has non-severe hypersensitivity, then you can prescribe the cephalosporin. And which cephalosporin you prescribe them or for oral intake is the cephalexin 500 milligram orally 6 hourly. If the patient has immediate severe or delayed severe hypersensitivity to penicillin, then you can prescribe them trimethoprim plus sulfamethoxazole, or you can prescribe them clindamycin. Okay, so this is the topic that we have covered for the salivary gland infection. So you can just read about and try to remember the causes, which might be the reason why your patient might be having any salivary gland swelling, and then if there is any antibiotic need. So the management would include the urgent referral, and which would be like, firstly they would drain the pus, they would do the treatment, and then the IV and the oral continuation therapy. Okay, so tomorrow we will start with the next most important chapter, which is the oral mucosal diseases. All right, thank you so much guys for watching my videos, and I'll see you in next time.